Department. Good morning. Thanks for being with us today. I'm Dan Tsai, the Director of the Department of Public Health, and I'm joined here with colleagues who are physicians. And as always, we are here to announce the overdose numbers for this month. I want to thank the Office of the Chief Medical Examiner for the work and for providing this information. And before I share the numbers, I just want to again note that every overdose death we have here in the city and county of San Francisco is preventable, and it's unacceptable, and it's tragic. And the current approach of what we've done historically here has not delivered the results that we need. The only way to tackle this epidemic is through even more proactively and urgently tackling the root cause, which is untreated or insufficiently treated addiction, mental illness, homelessness, and doing everything possible we can here. So without further ado, let me share the numbers, and then I will actually then step back out to share some of the overall initiatives we have going on at the department. So the preliminary number of accidental overdoses for the month of March is 65. 65 accidental overdoses in the month of March. That remains in range for what we've already seen this year. In February, we had 68 deaths. January, we had 59 deaths. So that means for the first quarter of this year, January, February, and March, we had 192 people die from accidental overdoses, or a monthly average of 64 deaths, or over 2 people per day. 2 people per day, over 2 people per day. And as I noted, every overdose death is preventable, it's unacceptable. And I want to be clear, as a department, we are not content nibbling around the edges, looking at whether these monthly overdose numbers move up by a handful here or there. We have an epidemic before us, and we're going to be tackling it as such. And some of the things that we have previously outlined and what we're calling a DPH roadmap for really tackling this epidemic involves strengthening and building a system of behavioral health care and treatment that does a better job of connecting everybody in need of treatment and supports to effective treatment and to sustained recovery. And that includes a few pieces, and then we're going to highlight what I think is an incredibly innovative, exciting program that we're going to be expanding. But on the DPH roadmap, that includes more treatment beds, more treatment capacity, including in shelters, so that when we have somebody engaged with the system, we're able to provide treatment and services and support to help that individual move through their journey of treatment and recovery. Second, we need to be able to do a better job of engaging folks on the street and quickly linking individuals to shelter, to treatment, to services. Too often it's too complicated and too difficult to quickly connect people who are ready and willing and able to engage in treatment and services. And three, our system of care needs to be able to better guide people end to end through every step of treatment and recovery. That's from initial engagement, that's from what our street teams are doing every day, to long-term recovery to really break the cycle. And underlying all of this, including through some of the recent updated policy on safer use supplies that we've announced, is a much more proactive, urgent posture to tackling this epidemic. And so one of the programs that I want to highlight and announce that we are going to be expanding is a really exciting program called Restore. Restore is a critical part of our strategy to reduce overdose deaths and ensure that people experiencing homelessness have access to the treatment they need immediately. It's a model that pairs shelter, meaning a bed, with immediate access to treatment and recovery supports at the same location, real time, And it breaks down a lot of the barriers that we often see when we're out on the street engaging people. What makes Restore so different from the myriad of other programs that we have is the urgency, the engagement, and the connection between bed and treatment. So number one, we have very proactive engagement. Our street teams on the street will identify somebody who needs a bed, wants a bed, may not be always willing to enter a more structured residential treatment program, but is willing to enter, to accept a bed in the Restore program. What that bed also comes with is an agreement from that individual to start treatment. We're also able to basically immediately at that moment engage and start individuals in treatment, including through telehealth prescribing to initiate medication assisted treatment for opioid use disorder, and it's an incredibly powerful tool. When I've been out in the evenings or during the day with our street teams, engaging individuals who sometimes are unwilling to or have been unable to access care, the availability of the Restore program is one of the most effective tools that we have in being able to quickly help that individual get off the street and into a more structured treatment environment with a bed paired with it. Part of what we're announcing is that we think that model is it's innovative. It's part of what we're doing in San Francisco. We are going to be expanding that. We currently have about 35 beds in the city in this program. We're going to be ramping that up to 70 beds, and we think that over the course of time, we actually need closer to 150 to 200 beds of this program Restore. So the work doesn't stop there, but it's something that is incredibly important, that is kind of the tip of the spear for when we're out, our teams are out in the street, and how we're engaging with folks to very proactively plug people into treatment and to also tackle the overdose deaths. So with that, I think we're gonna take some questions.
How long have you been implementing the Restore program?
So we started kind of as a pilot over the past 12 months, working through some of the details. We have found it, like I said, to be an incredibly powerful tool. I can't quite explain how much of a game changer it is. When you talk to our teams on the street, they will tell you that the availability of a Restore bed completely changes the type of discussion they can have with a client, with an individual on the street who is wanting a bed. It's a non-congregate bed, meaning it's a bed that's not, it's not a room with 10 other people, and it's low barrier. Folks are agreeing to treatment, to starting treatment as part of entering that program. It's a short-term program, 7 to 14 days to really stabilize folks. There's a requirement to engage in daily case management. You're initiating treatment, and there's very proactive planning to help that individual then ideally get plugged into a longer-term residential treatment program or other services and supports.
I saw Luz and then Catherine, then we'll go Natalia.
So you talked about the first 35 beds. What's the success rate that you guys are noticing within that first group of people?
The success rates are unlike anything we've ever seen with any other intervention we have. So number one, people who are agreeing to enter the Restore program have a bed and actually initiate treatment. And so almost everyone is immediately initiating treatment, and there's a requirement to actually engage in that daily case management. We're also very successful in, after stabilizing somebody over the course of 1-2-ish weeks, being able to work through with them what's actually the next best place for them, maybe a longer residential treatment program. So I can think of very few interventions that we have from a public health standpoint where we're getting people plugged into a bed and initiating treatment literally immediately. We will do telehealth prescribing to start someone on medications for opioid use disorder that same day, or if it's in the middle of the night, we'll do telehealth prescribing in the middle of the night. We'll get them to the pharmacy the next morning. They're initiated on treatment. They're starting case management that next day. That's unheard of. And so I think the sort of urgency and the types of tools we need here in San Francisco to tackle the epidemic that we have, this is a perfect example of that. And every single night, I think one of our biggest barriers is we only have 35 beds, and there are people on the street who are willing to start treatment in this sort of setting. The issue is we don't have enough capacity. So that is why we're announcing we're going to be expanding that to 70 beds relatively quickly, and then looking to expand further beyond that.
Catherine, I know do you have a question?
Yeah, so just a trends question. So last year we saw overdose deaths fall quite a bit, especially the second half of the year, and it seems like so far the first half of this year it's going back up. Can you share some theories for why that trend has kind of turned?
Yeah, I appreciate that. I think there's no single cause or single silver bullet one can describe around what's happening. I think for me, for us at the department, I just want to say every single one of those deaths is preventable and unacceptable. Our focus is going to be on moving upstream to get to the root cause of overdose deaths, which is untreated addiction, mental illness, combination of that with homelessness, and building a more responsive system of behavioral health care that can quickly get people into effective treatment and all the way through to sustained recovery without having to fall through the cracks. That is the only way we will be able to tackle the numbers that we're talking about with respect to overdose deaths.
Natalia.
Yeah. how are you
Excuse me.
No
Thank
problem. How are you planning to, I guess, identify more sites, more beds for the Restore program when the Adante's lease was winnowed down recently to just a year with a potential year extension, and that site has a good number of beds that are part of this program that would then be lost?
So I want to say we've been very, very closely engaging with a whole range of stakeholders, including a lot of the community around the Adante. What's really important is to make sure that one, at the Adante, we're transitioning some of the beds from a pure shelter-only bed to this sort of restored model that pairs a bed with treatment. And we've also committed that we are looking for additional locations and spaces to be able to grow the number of beds we have available. That is going to be a very thoughtful process that will involve engaging the community and finding appropriate sites.
Sorry, how many beds are you transitioning at the Adante?
We currently have 35 beds at the Adante, and we expect to be transitioning most of the shelter-only beds into this sort of model. Again, it is treatment. It is structured treatment that has a bed and required treatment with that, and we will be looking at other sites across the city to transition and also expand the Restore program. We think we need more than one site for Restore. We don't think it's appropriate to concentrate a Restore program only in one area. There are people all across the city in different communities in need of these sorts of programs, and that's the sort of approach we'll be taking as we look to see how we thoughtfully expand this really incredibly, I think, innovative and effective model.
Did you have one more?
Sorry, first just a quick question. Where's the current location for Restore?
The current 35 beds are at the Adante Hotel on Geary Street.
And just like a follow-up, so like this like proactive program, are you running into any issues expanding it with Mayor Lurie's plan to kind of reduce a lot of harm reduction programs through DPH?
To me, we have a continuum of supports that we need to really tackle the epidemic. The safer use supply policy we outlined the other week, is a different piece, but underlying that is a desire to be much more proactive with folks of getting people quickly into treatment. The Restore program is exactly that sort of thing, where we can provide someone's housing or shelter needs, but pair it with treatment, and pair it in a way that doesn't involve, hey, go to a shelter, find some other location for you to actually start treatment, having to coordinate a bunch of things. We can do it all at one site, and we can do it all basically at real time and immediately. That's part of what's so powerful and exciting about this sort of model.
Okay, last three questions right here. Natalia, and then Luz. Natalia.
Yeah, so 822 Geary was initially proposed as a safe consumption site when we got acquired in 2021. Can you just confirm that that's no longer going to be a part of it, and is the department in support of possibly exploring safe consumption in the future?
822 Geary is not a safe consumption site, full stop, period. It is, it will be, when it opens, a crisis stabilization unit, which is a state licensed level of care. It is a really incredibly important part of how to respond to people in crisis with addiction and mental health needs. It's a model that other parts of the country have employed much more than we have in San Francisco, and so we're really excited about that.
Are you at all interested in sort of exploring safe consumption for future or something?
That's not on the table.
And last two
I
here.
don't know if it was made clear, is every overdose death a fentanyl-related, death?
No, that's in the report. The breakdown is in the report from the Office of the Chief Medical Examiner. The majority, something like 70%-ish of the overdose deaths are linked to fentanyl in some way.
Luz?
Two questions. So what's your projection of how many people in San Francisco could benefit from the recovery program that you're talking about expanding now?
I think our sense is that we will need closer to 150 to 200 restore type beds across different parts of the city. We don't have those locations all outlined yet. Part of this is us trying to build a clear system of care that can be responsive to the needs that we're seeing. And I want to be clear also, the restore program is meant to be an immediate stabilization sort of program, getting someone plugged into treatment 1, 2, 3 weeks, initiated on treatment, and then we're working with that individual through daily case management and other treatment supports to help get to the next step of their treatment journey. So it's not a static number, so to speak. We think we will need eventually 150 to 200 beds.
And I was just wondering, so what happens after that? So you said 1, 2, or 3 weeks, and then what happens? Do they lose that bed? Are they put into any sort of housing after that?
Those 1, 2, 3 weeks, I want to be clear, it is an incredibly clinically oriented period of time where someone has not only initiated treatment, they're going through daily case management. And from that moment, there is that case management and clinical support involves identifying what are some longer term treatment and recovery options, including, for example, whether it makes sense for somebody to actually enter a structured residential treatment program that could be, 90 days, 3 months, 6 months, and actually doing the placement, making sure there's a bed available, helping that individual transition from the Restore program into a residential treatment program. Those are the types of things that are happening over the course of that 7, 14, 21-day period, which is why it is such a powerful and exciting model.
You guys.
Thank you, everybody. Appreciate it. Thanks.